Good afternoon, and welcome to this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. Today's webinar is entitled New Year, New Health Plan. This webinar is being recorded and will be available to the community beginning on Friday, January 19th. Before we get started with today's webinar, I would like to mention that there will not be a Wednesday webinar next week. We invite you instead to join the National Research Blueprint Summit. The summit will present recent progress on this community-driven 4-year journey to shape the future of research for bleeding disorders. You can see in the Zoom chat a link to register for the summit. This is free and open to everyone. Also in the chat is a second link to the NBDF webpage with more information on the National Research Blueprint. The summit will start at 12:45 p.m. Eastern, the afternoon of Thursday, January 25th, run all day on Friday, the 26th, from 8:45 a.m. to 5 p.m., and then wind up on Saturday, the 27th, from 8:45 a.m. to noon. Of course, you're not obliged to attend all 2.5 days of the summit. You're invited to register and attend as much as you can. NBDF places great importance on engaging with all aspects of the community around this important endeavor and encourages everyone to consider this virtual option to attend the summit. Today's webinar, New Year, New Health Plan, will be presented by Ryan Faden, Director of Patient Access at the National Bleeding Disorders Foundation, and Mark Hobrach, Senior Manager for Policy at Hemophilia Federation of America. After the presentation, Ryan and Mark will be joined for the live Q&A session by Nathan Schaefer, Senior Vice President of Public Policy and Access at NBDF, and by Miriam Goldstein, Director of Policy at Hemophilia Federation of America. We encourage you to ask any questions you may have today. You can ask your questions by using the Q&A feature at the bottom of your screen at any time. We will monitor these questions, and following the speaker's presentation, we will put your questions to our expert guests. I'd like to thank Ryan, Mark, Miriam, and Nathan for joining us today, and I will turn things over now to Ryan to get us started.
Thank you, Fiona.
Thank you, Fiona. This is Nathan Schaefer, and I just wanted to say a couple of words before Ryan gets us underway here. We really wanted to have this webinar with all of you at this time of the year because we continue to hear about formulary exclusions and restrictions. As more and more bleeding disorder treatments become available, we have seen cost containment measures being implemented for reasons that we understand. But those cost containment measures must not come at the result of patients experiencing negative health outcomes. So we really endeavor to understand and document the prevalence of the problem when it comes to restrictions or exclusions to clotting factor that is necessary for the health and well-being of the patients that we represent. So today we're going to give you an overview of what we have seen to date in terms of formulary exclusions and restrictions, and more importantly, what you can do to help us as national patient advocacy organizations understand the breadth and the depth of the problem when it comes to the patient experience. We will walk you through specifically how you can share your experiences, confidentially, of course, that will help us augment and hone in on our advocacy strategies going forward. So with that, I'm going to turn it over to Ryan, who we're very excited, who joined the team at NBDF late last year. You'll hear from him a bit of his background and an overview of the situation. Miriam and I will be back in a little while to answer all of your questions. Thank you again for taking the time out of your busy schedules to join us today. Ryan?
Thanks, Nathan. Hello, everyone. So as we begin, I wanted to just take a brief moment to share the National Bleeding Disorders Foundation's mission. The National Bleeding Disorders Foundation is dedicated to finding cures for inheritable blood and bleeding disorders and to addressing and preventing the complications of these disorders through research, education, advocacy, enabling people and families to thrive. So on today's webinar, this slide basically lays out what we're hoping to accomplish. So we're going to actually start off with a polling question for the group who are participating in the call today. Then I'm going to introduce myself and talk a little bit about my background. Then Mark will do the same. Next, we're going to share a participant survey instrument, which is where we're hoping to collect data about the current situations and how formulary restrictions are impacting access. Then we're going to kind of get into the meat of the presentation, and again, talking about the threats posed by the formulary changes that we've seen happening in the new plan year, sort of continuing a trend that's been well documented in 2023 and before. And then finally, we're going to conclude with Q&A. So we hope that you all will have some questions so we can have a good discussion. So you see the polling question on the screen. If you all could respond to that, we're actually going to keep that open as we continue with the presentation. So I'd like to take the opportunity to introduce myself and talk a little bit about my experience. As Nathan mentioned, I joined the National Bleeding Disorders Foundation back in November of 2023. But I have spent many years working with the bleeding disorders community, actually going back all the way to 2006. So I am very pleased to be in this role representing the foundation. My work with the community primarily stems from prior roles with CSL Behring and state government affairs, as well as the Plasma Protein Therapeutics Association. And through all those experiences, then NHF and now NBDF was a primary focus of that role, and I had the opportunity to engage very closely with state and national chapter officials, and kind of have a strong understanding of the issues that the community has been facing. I also have significant work experience both with Medicaid and private insurance, which I feel will allow me to have a true 360-degree view of the issues that the community faces and help with engagement. And I'll be the primary point of contact for insurance issues arising for individuals in the community across the country. So we encourage you all to reach out to me as those issues arise, and we can work to find solutions. And then more broadly, I'll be helping to lead public policy efforts in addressing access issues. So with that, I'm going to turn it over to Mark briefly to introduce himself as well. Thank you.
Sure, very quickly. My name is Mark Hobroch. I have been with HFA since 2019, but before that, like Ryan, had significant experience working with the bleeding disorders community. First with the Access program when it was part of Accredo Health Services, and then with Patient Services Incorporated, the Premium and Copay Assistance Foundation. Before that, I had worked not only with a Medicaid program, but for a manufacturer and a couple of associations, trying to help people with what I thought at the time were high-cost conditions to get coverage through Medicare, Medicaid, and private plans. Currently, I am the primary HFA contact for access to care issues.
Great. Thank you, Mark. Greatly appreciate getting to provide this important information, partnering with you at HFA. So we'll move on. The next slide is a link to the survey instrument that we put together to help collect data from the participants in the webinar, primarily around trying to gain some insights into what some of the impacts of these formulary restrictions that we've seen and are continuing to see, what the actual impact of those are, and then once we are able to digest that information, it can be very powerful in working with policymakers to try to arrive at solutions to those issues. So if you're able to complete the survey, it doesn't have to be during the webinar. It's going to be remaining open. But we feel that information will be very helpful to our ongoing advocacy efforts. So when we were thinking about putting together this webinar, it's a very timely opportunity, given that we're in January of a new year. I think as most people are aware, one of the most common times to see so-called surprises with formulary situations is often at the beginning of the year. People may not be aware that plans have changed with respect to coverage of their prescription medicines. So this slide basically lays out a few different scenarios. This might not be all of the scenarios, but I think it just shows that, so the first one, are you continuing your plan selection from a prior year through your workplace? So that's where people are staying on their same exact plan. And I think a lot of people believe that if you're staying on the same plan, that you don't have anything to worry about, everything's going to be the same, but that's certainly not always the case. So even if you're staying on the same plan, you may find that there's been changes to the formulary. Another common situation is, are you starting in a new plan with your current employer? So there you might have done some research in terms of what the formulary situations look like. But I think I would say that even for experts on formulary review, it can often be difficult prior to actually being signed up for a plan to know all the details of what the formulary might look like in practice. So unfortunately, it's very challenging to anticipate what some of these issues might be. And then finally, are you covered by a plan bought on the Affordable Care Act marketplace? And of course, those change on a regular basis. And in the case where you're buying plans on the marketplace through the Affordable Care Act and not through your employer, it's more important to try as best as you're able to research and get an understanding of what's included in your formulary and on the plan in terms of the full slate of benefits. So when we talk about formularies, I think admittedly that there's often some logic gaps, if you will, where we sort of make assumptions that people understand some of the terminology that's thrown around, and so we thought it would be helpful to just take a couple minutes just to talk about like what goes into formulary design. So what are the principles of formulary design? What are some of the things that impact what those formularies ultimately look like on the plans? So the first slide talks about formulary design for private payers. And so we've kind of segregated private payers versus public payers, and in this case, Medicaid. But starting with private pay, the first step, of course, is drugs are approved by the FDA. And again, this is sort of a 30,000-foot level, like say a situation with a new drug is coming to market. Plans and or their associated PBMs can demand rebates from prescription drug manufacturers to ensure preferred coverage. If the parties don't arrive at agreements that are acceptable on both sides, in many cases, plans choose to restrict access to certain products, and that can even include excluding products from formularies. Again, this is on the private side. Patients can appeal exclusion decisions. However, unlike Medicaid, there is no actual requirement that plans have to have a coverage pathway to all products. So switching gears to the case of Medicaid, again, drugs are approved by the FDA. States can either so these are each individual state runs their own Medicaid programs. I think that's a key thing to keep in mind as we're talking about advocacy. So states can either add a new drug to their covered drug list, or in some cases, if there's multiple products in a particular drug class, they may seek supplemental rebates from the manufacturers. So this next point, I think, is really key. It's something that is a central aspect of how Medicaid covers drugs. So technically speaking, Medicaid is required to cover all FDA-approved drugs where the manufacturers have signed Medicaid rebate agreements. However, states still have significant discretion in how this coverage works in practice. And so one of those levers for their discretion is negotiating those supplemental rebates that I just mentioned. They can also put in place other hurdles where things like step therapy, fail first, situations where they would expect Medicaid beneficiaries to take a preferred drug first and have some complication or untoward event before they might approve coverage for the non-preferred product. And that's an issue that the community has had issues with and engaged on for many years. And then if the states, abuse the discretion in the cases that I just mentioned, patient community and manufacturers both have, attempted to challenge those decisions and one of the central pieces to challenge those is that, going back to federal law under the Social Security Act, which basically requires that Medicaid does have a coverage pathway for all products, and they shouldn't make arbitrary decisions in terms of what drugs are covered and which ones are not. So the next slide I think is interesting because it sort of provides a snapshot of what the trend has been in terms of the growth in formulary exclusions. And you can see from the graph, which is depicting formulary restrictions among three of the largest national PBMs over the last roughly 10 years. And you can see the significant increase there. I would also encourage folks to save this this link because there's some excellent background information in the drug channels story where this graph is taken from. And one thing I would just point out in particular, one of the supporting documents was a study done by Xenda, which shows some higher rates of complications and problems with quality of care in patients that have been subject to these exclusions. So what I'm going to do now is throw it over to Mark, who's going to share some additional specifics about issues that have been faced with these formulary restrictions in recent years. And Mark, let me know when you'd like me to advance the slides as well. Thank you.
Sure. Thanks, Ryan. Well, the biggest reason we've seen such an explosion in the number of formulary exclusions or even the threat of it, if we can go back to the last slide, please, Ryan, is because this enables plans to get a lot more leverage over manufacturers in terms of the rebates that they can get back. On the next slide. And there are a couple of really good large-scale examples of this that we've seen. One is with the national formulary for CVS. It was one of the big three that Ryan just mentioned. They actually exclude all standard half-life products. And because of that, well, also we've seen in Blue Cross Blue Shield of Tennessee, which is by far the dominant player of Tennessee, we've seen another very broad exclusion where basically all of the bleeding disorders products, or almost all of the bleeding disorder products over the last 2 years have been excluded from the formularies. This is something different than we've seen in previous years and really kind of goes against what federal rules say. We've seen the federal government willing to act in these situations in other contexts, and so that's something we're certainly working on at present. Here you can see a list of the national formularies for the big three. These three PBMs are responsible for something like 3 out of every 4 prescriptions that are filled in this country. So it's a fairly representative example of what we are currently seeing. For example, under the CVS or the Optum Rx, Hemlibra is not included. Now, there's no specific exclusion, but because it's not included on there, it can make it very difficult for a patient to be able to get that product without having to go through a lengthy exceptions process. CVS, we've also seen, again, no products for von Willebrand's disease, the type of broad exclusion that we thought could not occur. And then under CVS as well, we've seen all standard half-life products for factor IX, some extended half-life products also not included. And then you have no products for entire rare conditions apart from bleeding disorders. Next slide, please. So I think we're all familiar with some of the long-term adverse health outcomes that can result when people aren't able to get their medication in a timely process. There is an exceptions process that is required, so you have the right to request that from your health plan. However, that can be, depending on the plan, not a quick process. Typically, they're required to respond within 72 hours or 24 if it's an urgent case. But your ability to do that really depends on being able to get your doctor on your side. It will come down to having to make sure that you can make an argument that that product is medically necessary, that there's no alternative for you that you can get. So even if you're successful, you can experience a delay, sometimes a long delay in getting that prescription filled. And that can result in things like a breakthrough bleed, obviously joint damage or other complications from having to be treated in an emergency room setting instead of an HTC. Next slide, please. Now, patients can also be required to switch for non-medical reasons. We've seen this often in the context of what's called step therapy or fail first, where a plan can say you have to try a product that is typically cheaper, but on the formulary, maybe a lot less effective for you, harder to self-administer. Or there are certain side effects that may result from that. And so you'll have, again, long-term complications. So in order to overcome that, it's important to be able to show from your physician that there is a better product that is prescribed for you and the reasons why it's medically necessary. And it's not just the adverse health outcomes that can result. Obviously, there are huge out-of-pocket costs that you will incur if your medication is not on the formulary. And I think that's where I throw it back to you, Ryan.
Thanks, Mark. Appreciate that. I think one final point just before we move on to the next slide is the importance of this issue of demonstrating medical necessity in terms of the appeals process. One thing that you may hear in these discussions is that payers are often unwilling to pay for so-called convenience of say a product that's not preferred. So convenience alone often isn't enough to overcome a plan restriction. But the importance of physicians being able to demonstrate medical necessity is certainly something that's a focal point in challenging formulary decisions. So switching gears a little bit is the next couple slides try to provide a sort of a roadmap of what the National Bleeding Disorders Organizations, NBDF, HFA, and others and other groups representing rare disease communities are undertaking to tackle the problem associated with formulary exclusions. So one area that's been very successful to date is that we've advocated that insurers, as well as their associated PBMs, provide all products, all FDA-approved products, and to support that, letters have been written to Blue Cross Blue Shield of Tennessee and CVS. Meetings have been requested with officials. In addition to advocacy with plans and PBMs, the organizations have also advocated with both state and federal regulators to take enforcement actions where formularies are inadequate. Unfortunately, those regulators to date have often taken narrow readings of the relevant requirements. and largely have decided that the reduced formularies pass muster under the legal requirements. We've continued to argue that there should be more expansive interpretations of the relevant laws. For example, we submitted comments in early January urging HHS to enforce existing standards stating that plan formularies must provide appropriate access to drugs that treat all disease states, importantly, on a non-discriminatory basis, and also relying on broadly accepted treatment guidelines, again, rather than some of the arbitrary decision-making that has occurred in some cases. We also, as the National Bleeding Disorders Organizations, we also provide insurance literacy education and outreach on issues such as health plan selection during open enrollment and how to pursue insurance appeals. And I know the links to these resources will be put up in the chat as well. So next, in terms of a call to action for patients, healthcare providers, chapter leaders, is to basically what can you do to impact these concerning formulary exclusions that have been occurring and are continue to occur. One suggestion is to connect with manufacturer patient assistance programs to help avoid temporary gaps in your access to medications. But one cautionary note there is that free product through patient assistance programs are certainly not a long-term solution. Healthcare providers' submission of well-documented exceptions requests, especially like we talked about a little bit earlier, making the case that access to a particular medication is a matter of medical necessity. And along with that, the more documentation that can support that assertion of medical necessity, the more effective those appeals tend to be. We've also provided some additional resource links on this slide as well, from both HFA and NBDF, as well as the AIMED Alliance Know Your Rights document and the Patient Advocate Foundation, focusing on how to engage with insurers. So we ask again to utilize the survey that's included with the webinar, and also to stay in close contact with the national organizations and working with your state organizations so that we can provide assistance, and also with your permission also utilize some of the specific issues that have occurred when formulary exclusions have had negative impacts on people's health and well-being. So this slide just basically asks again if you're able to fill out the survey. And one note that we wanted to mention is that we're also working with allied patient advocacy organizations to engage in the same exercise to basically help us to collect the most helpful information to support our ongoing advocacy efforts. So next, what we wanted to do is re-ask the polling question that we started the presentation with, just to kind of see, after hearing from us on these issues that we've presented, whether you all feel that you have some additional information that could help you, as whether you're from the provider standpoint or from the patient standpoint or the patient advocacy standpoint, to address these formulary challenges. So at this point, we would like to take the opportunity to open the webinar for Q&A. So with that, we'll open the Q&A, and I think we're all looking forward to some additional discussion and being able to respond to the questions that are raised. Thank you.
Great. Thank you very much, Ryan and Mark, that really interesting presentation and for all of those resources. As people fill out that second poll, I just want to take a moment to offer a quick reminder and recap to our audience to take a look in the Zoom chat. We've been dropping all kinds of great links in there. So take a look at the bottom of your Zoom screen. You should see a chat option, open that up, and you should see a series of links. The first at the very top of the chat history is to register for the NRB Summit that I mentioned at the beginning. And then there's one with information about the National Research Blueprint. And then we have the link to that form that Mark and Ryan were talking about, where we invite you to fill out your experiences around these issues. NBDF and HFA would really appreciate your input here. Then there was the link to the source for that multicolored graph that Ryan showed. 3 links to representative examples of 2024 national formularies, and that whole series of links to some really excellent resources. So take a moment to look at those and maybe copy save them somewhere so you can continue to access them after the webinar ends. So I think we will close the poll now. Thank you everybody for filling that out. And we will go ahead with our live Q&A. And joining Ryan and Mark for the Q&A, we've got Nathan Schaefer, Senior Vice President of Public Policy and Access at NBDF, and Miriam Goldstein, Director of Policy at HFA. Thank you both for joining us. Reminder, if you've got a question, you can put it in the Q&A box at the bottom of your screen, and we'll do our best to answer all of your questions. Nathan, I think you wanted to start with a quick word about Washington Days.
Yes, please. First, thank you, Ryan and Mark, for those excellent presentations and overviews of the areas of concern for us today. I did want to mention our upcoming largest advocacy event, Washington Days, which will take place March 6th through the 8th this year. This is our annual advocacy event where we bring over 400 patients, providers, and invested community members to Washington, D.C. We provide extensive training about what it's like to go to Capitol Hill and meet with a congressional office about issues that are of utmost concern to the community. If you've never been to Washington Days before, if you've never been to Capitol Hill before, rest assured we will give you all of the resources, the practice, and the experience required for you to have a successful visit with your elected officials. We will, again this year, be talking about insurance trends and the dangerous practice of accumulator adjusters, supporting our top legislative priority, H.R. 830 and Senate Bill 3175. We will also be talking about Bleeding Disorders Awareness Month, kicking off March, and of course, the importance of federal funding to support the network of hemophilia treatment centers providing comprehensive care for the bleeding disorders community. I'm going to drop into the chat the link to register for Washington Days. You will see that the deadline actually has passed. It was this past Monday, January 15th, but we've extended it for a few more days. So if you have not yet registered for Washington Days, please do so. If you are someone who is in need of travel assistance to make your participation a reality, we encourage you to check with your local chapter. They tend to have opportunities available for consumers to be able to attend Washington Days, and we hope to see many of you there. Thank you.
Great. Thank you very much, Nathan. So we have a couple of questions that we have had come in. I'm going to take moderator's prerogative and just start with a couple of very basic questions. So for example, if I have a plan and something has changed about that plan, is my provider obliged to inform me? Like if my credit card conditions change, my bank has to tell me. Do people receive any kind of notification if their plan changes?
I can take oh, go ahead, Miriam. Sorry about that.
No, I was going to jump in and say for people who are continuing on the same plan, typically the same employer plan, they hopefully did receive a letter in the fall from their insurer advising them of a change, but letters don't always reach the intended participants or recipients. And so all too often, unfortunately, people are taken by surprise. We have started to hear from community members who did receive those letters. So we know some of those changes people are trying to process them right now, part of the impetus for this webinar. Ryan?
Sure. Thanks. I think I agree with that 100%. I think the one thing I might say too is sometimes in many cases, a letter that may be received doesn't adequately explain what the change might be or what the significance is. So it might say, oh, we're now using this new prescription advantage program or something like that, but it doesn't really say how that's going to possibly impact you later and your individual prescriptions. So that's one thing as well in terms of overall transparency often isn't there in those notices to beneficiaries.
Right. I mean, I've got to admit my statements from my bank are not super transparent either. Another sort of very basic ignorant question, I suppose. What's the best way to find out if something has changed? Would you call your plan provider? Would you go to their website and like just do a search for the name of the medication you're concerned about? Or what's the most straightforward way for someone to investigate that themselves?
So I think that every plans are required to provide detailed documents. They're usually in this stage, usually electronic. It's rare to get like the full thick summary of benefits at this point. So it is probably a good practice for people early in the year to see if they're able to locate the detailed formulary information that's associated with their plan to see if there have been any changes. However, sometimes, and we kind of discussed this in planning for the webinar, sometimes just looking at that two-dimensional page doesn't always tell you what's happening, because sometimes things may be omitted, but it doesn't mean that they're excluded. It may just be that they're in a different category, or maybe they've moved them to the medical benefit and they're no longer in the prescription benefit, things of that nature. So it's difficult to, unfortunately, it's not just a matter of looking at the list, but it's also starting looking at the list, but then taking that next level and maybe asking people who you know that may be experts on formularies for additional assistance.
Right. Thank you. So I've got a question from one of our audience members who says they'd like to know if an HTC prescriber prescription attestation, if that's enough to achieve medical necessity, or is a factor level test or some other measurement also required? It seems like some payers don't understand women and girls are denied factor outright due to gender and differences in bleeding patterns.
I wish I could say that we knew the formula, but we don't. And part of that's because each plan goes through a different review process. We know that sometimes when these questions go to an external reviewer, the plans may employ doctors who aren't remotely expert in hematology. I think that's why throughout we emphasize those points that Ryan and Mark made about working with your healthcare provider, about documenting medical necessity, and honestly, I think throwing the kitchen sink in. So journal articles, I would say, the patient's own treatment records, including, past unsuccessful efforts to treat with products that still are on formulary. It's really, I just come back to throwing the kitchen sink in because it is so unpredictable.
Yeah.
I can just add that one of the key points for a physician to make is that a particular product is the only product that may be available for that patient, and explain why other products would not be suitable. So that's often, not always, enough to establish medical necessity, but it's it's a very key point to make, especially in a bleeding disorders context where there may be one product for that particular patient that works the best. And to show that there are no alternatives is what the plan needs you to demonstrate.
Right. Thank you. Someone's made another really important point here that I'd like to share. It's not exactly a question on the formulary, but they do raise the point that women are not getting the care they need due to non-diagnosis. And how can we fix that? And I don't know if you'd like, I know you can't answer that necessarily because that's a huge question. Would any of you like to say anything about, I know there is a lot of work that's being done by your organizations on behalf of that situation. That is something that you're aware of. Just want to give you an opportunity if you want to just say something about that, maybe Nathan, Miriam.
Yeah, I can tell you that last year, 2023, NBDF convened a Women and Girls and the People Potential with the Potential to Menstruate Summit. And out of that came a white paper with a comprehensive list of potential solutions and avenues to try and rectify the inequities experienced by women and girls living with bleeding disorders. We have been sharing that white paper with key allies on Capitol Hill. We don't have a comprehensive piece of legislation to address the inequities of the experience of women and girls with bleeding disorders yet, but we are beginning to try and identify who might be appropriate champions and how we can advance the needs of all members of the bleeding disorders community.
And I will just add, hopefully working hand in hand with that effort, some HFA convened a working group and a conference last year that led to a published paper, peer-reviewed paper this year about gaps in research for involving women with bleeding disorders, and hoping that that also helps advance the conversation. Also have had some training sessions, trying to do outreach to OBGYNs, alerting them to things they should be on the lookout to make sure that to try and shorten that pathway to diagnosis, which is, step one to getting the care that is needed.
Yeah.
And then just to add one additional point, I think that it's clear that progress has been made as Nathan and Miriam discussed some of those initiatives. I think looking back historically, I think one way we can see that progress too is years ago, women were exclusively referred to as asymptomatic carriers, and that's something that doesn't apply anymore. That terminology is no longer in use. So I think that's also a sign that progress has been made in addressing the impact that the bleeding disorders have directly on women.
Right. Yeah. Thank you. And I will take this chance also to make another plug for the NRB Summit. The National Research Blueprint does include in its goals to make research really reflect the needs of the entire community. And that includes women and girls and people with the potential to menstruate. And so come to the summit next week and see how that might also contribute to moving all of that forward. So there's another question that's come from one of our audience members, and I will read it to you because I don't know this area well enough to know precisely what it means, and you can tell me if you have an answer for them. They're asking, how do we disconnect insurances from using their RX? And I'm wondering, does that mean their prescribers or their prescriptions? Is that something that is clear to you?
It's I don't know if it's possible that it's a comment about the increasing consolidation of insurers and PBMs where they've basically they're kind of controlling both ends in many cases. So we've seen a lot of that consolidation over the last 10 years, and so that is interesting how that's corresponded with some of the increase in formulary restrictions. So that could be what they're talking about.
I think they've clarified here at the bottom, and they said their pharmacy. So are they sometimes requiring to use a specific pharmacy? And is that maybe they're asking, how can you kind of decouple that?
There has been a huge amount of, I think the technical term is vertical consolidation, with insurers owning PBMs, in turn owning specialty pharmacies. Sometimes it's even flipped in the CVS case. CVS is a huge national PBM and it owns an insurance company. CVS is big enough that it flipped the script and it owns Aetna, I believe. I can tell you that the Federal Trade Commission, so usually when us on this call work on health policy issues, we are talking to federal health regulators. In this case, the Federal Trade Commission, which is the US government agency charged with enforcing the antitrust laws, they have launched an inquiry into vertical consolidation in this very field. And we have been commenting in the FTC proceedings and are hopeful. Don't know how soon or how extensive the FTC may act, but it is under review.
Thank you. And thank you to the person posing the question for the clarification. Apologies for not getting that right away. There's a question from someone who I think, they maybe are making a point that maybe a lot of people are sort of feeling. How can an entire disease state, for example, VWD, not have any products on formulary when products are approved by the FDA and indicated for treatment?
I will jump in here again just to highlight some of the many, many complexities in this area. There are different regulatory schemes depending on where you get your insurance. So if you have ACA insurance or individual insurance or what's called a fully insured plan, there are more requirements on what your plan has to cover, and it is less likely that your plan can make that kind of blanket exclusion. Unfortunately, in the employer space, which we sometimes call the ERISA those plans are exempt from state regulation and exempt from some of the ACA requirements. And that is where we see some of those blanket exclusions that are so very, very hard to fight back against. That is part of the reason for this webinar, because if everyone out in the community is dealing with these issues on their own island, they're harder to tackle. And so we are very, very hopeful that we can come together as a community, gather these stories and speak with one unified voice and impress on policymakers the need for a change, including for a more robust interpretation of the rules that apply to ERISA plans and more robust enforcement of those rules. we know that this is an existential problem for our community, and we are attacking it on every front we can think of, including, making the case that these formularies with blanket exclusions are inadequate, but also talking about the process and saying, health plan issuer, if you're going to issue a plan with these kind of exclusions, you need to put in robust avenues that patients can use to try and fight back and get the care they need. So I will get off my soapbox and give other people a chance to weigh in.
Well, and maybe before I do that, I'm just going to expand a little bit on that question, because I think we have a very similar question where someone's saying, well, what about when it's an exclusion so broad that it's broader than a specific drug, but rather exclusions on all specialty drugs or all tier 5 drugs? And especially when the plan states that no prior authorization, letter of medical necessity, appeal, or clinical reviews are available for this exclusion. This doesn't leave people with many options beside patients' assistance programs. I don't know if anybody would like to speak to that.
I think that's a very challenging situation, obviously, and Miriam kind of alluded to it in some of those plans that are in the self-funded space may be likely to have those types of approaches. I think that's where the importance of reaching out to the regulators in charge of that particular plan, whether it's at the Department of Labor, whether it's CSIO and HHS, if it's a marketplace plan, to try to address those concerns, because clearly it's a matter of not being educated about what should be included in a legitimate prescription drug offering. So I think it's incumbent to raise those issues with the appropriate regulators.
Great. Thank you very much. Well, that's with perfect timing that we've come to the end of the questions. Thank you, everybody, for your really great questions. And thank you so much to our guests for your really thoughtful answers. I'd like to thank Ryan Faden, Mark Hobrach, Miriam Goldstein, and Nathan Schaefer for sharing your experience and your time with us today. This recorded webinar will be available on Friday, January 19th at hemophilia.org under the events tab. If you select past events, you'll find all of our archived webinars there. And just as a final reminder, we really encourage everyone to register for and attend as much as you can of the National Research Blueprint Summit next week, from Thursday afternoon through to the Saturday noon. More information about the National Research Blueprint can be found on the NBDF website in the Research tab. There will therefore not be a Wednesday webinar next week, but we will be back the following week, January 31st, with a presentation on community voices in research. Thank you so much for joining us this afternoon, and I hope to see you at the NRB Summit.